Welcome to the Stat AI podcast.
Welcome to the future of emergency medicine, a realm where artificial intelligence isn't just a buzzword, but a beacon of hope and a tool for transformation. I'm DJ Apakama. My co-host Ethan Abbott and I are both emergency physicians, and we have witnessed firsthand the burgeoning role of AI in our field. Our everyday experience grappling with healthcare disparities and social challenges have led us to a pivotal question. In the wave of AI applications, what changes are coming to emergency medicine, and will they be for the better? This podcast was born not just to ask these critical questions, but to seek out answers from the experts, to understand and to demystify the potential of AI in emergency medicine. We believe in bringing this conversation to the wider community to embrace AI as a tool for positive change. This podcast is our exploration of that future, a journey we invite you to join. So let's embark on this path together to learn, to question, and to envision a new era of emergency medicine enhanced by the power of AI. All right. Hey, Ethan.
Hey, what's going on, DJ? How are you?
Good.
So today we're going to talk a little bit about this interesting article that came out recently in JAMA Network Open. Do you want to start us off and we'll kind of dive into it?
So the article is titled "The Use of a Large Language Model to Assess Clinical Acuity of Adults in the Emergency Department." We'll kind of just use the PICO format to keep this short, but the population was adults aged 18 and older visiting the emergency department, and this study was done at UCSF. Basically went from 2012 to 2023. They used large language models, which specifically GPT-4, to assess clinical acuity by identifying patients that had a higher acuity presentation from pairs of ED visits based on clinical histories. So I'll just repeat that. That was based on clinical histories. The comparison is basically human physician classification of patient acuity and performance of an earlier LLM, which was GPT 3.5 Turbo. And then the accuracy was the outcome that they were looking at. So the LLM was looked at for identifying whether or not it could reliably identify higher acuity patients in each pair with accuracy scores compared to those of human reviewers. Overall, they did 10,000 pairs over 251,000 adult ED visits. So pretty moderate size study. Their key findings were that the LLM demonstrated an accuracy of 89% in higher acuity patients in the 10,000 pair sample, which was comparable to human physician performance, which was around 88%, the 500 pair subsample. The LLM accuracy was superior to the previous model, so 3.5 Turbo had an accuracy of 84%, which was compared to, again, GPT-4's accuracy of 89%. And the performance was really good for patients with kind of an extreme difference in acuity level. So if you had, life-threatening injury versus a non-urgent injury, this model was pretty reliably able to distinguish between the two. And then overall, the authors concluded that integrating LLMs into ED workflows could potentially streamline the triage process and maintain some high-quality assessments. So I think there is a lot to discuss there. But overall, this was kind of a study that tried to look at how LLMs can be integrated into clinical workflows for overall to kind of help not just physicians, but also maybe patients.
Yeah, I thought it was a really interesting study, and I love, again, the fact this was used with real electronic health record documentation. These weren't sort of hypothetical cases. It was de-identified data, but it was certainly real emergency department patients. And I think, this sort of ground level work is nice. I mean, they chose to sort of look at almost like a sort of a binary outcome, looking at the LLM to return like one of two sort of options is what they had written. So patient A is of higher acuity or patient B is of higher acuity, which I think is a nice sort of simple initial experiment to test using technology. I I think one of the questions that I sort of had is, looking at ESI, which I think most of our listeners are probably familiar with, they didn't include vital signs. And then also, I think maybe one of the criticisms that I might have is also the usage of the downstream clinical note, because I think oftentimes the ESI is going to be derived from, again, the vital signs and then very limited clinical information or patient history that the nurse obtains at triage. But I do like the whole idea of this. I think it's just really, really, really cool, and I'm glad this was undertaken.
And I mean, that's such a good point that you raised, right? Because we all know how this works. It would be amazing if we could document in real time everything that was going on with all of our patients. But in reality, clinical care gets in the way. And sometimes, if you're like me, oftentimes you're documenting well after the encounter actually occurred, or maybe at the end of the shift. And what is, I think, important to remember about that time period is that I now have more information about the patient as far as how sick they were or where they're likely to end up. And so if you're basing your analysis off of that time period and not really the information you had when they were presenting at triage, so what that sorting nurse is dealing with is essentially the complaint and the vitals, right? So if you're not basing it off of that, I think there's two things that we could say: that perhaps if you included that, the model would be even better than what we saw, right? Hard to say, but that's a possibility. And I think the other thing is that without including that, then essentially we may be talking about two different things here. So it's an interesting thing to note. And like I think you said, probably the first step, right, in determining whether this is a useful application for LLMs. But I certainly don't think that it means we have to rush out and replace our sorting nurses with ChatGPT anytime soon.
Yeah, I totally agree. I think this is a great sort of start to thinking about application of large language models. I do think the future sort of like real world deployment is going to be much trickier than this. And it would be obviously cool to see the next steps with a more sort of prospective study that maybe runs this model in parallel with nursing doing the ESI and see how it performs comparatively in that real world test. But I think that's maybe quite a bit further down the line.
Another thing that I think you brought up when we were talking about this earlier was that who routinely establishes the ESI level at triage? Is it a physician or is it nursing? And generally speaking, at least at my shop, and I know most others, it's going to be nursing. So this study chose to compare essentially the output of the LLM to a group of people who do not normally do that job. That being said, I'm not saying that we can't do that job. It's just that we're not the ones usually applying that label. And then I think one other thing that kind of goes along with what you just said is that this study didn't analyze the LLM performance across different patient demographics, which would be essential to kind of ensure that equitable care. And I think there's no place that we want to make sure that we're doing that more than at ED triage. So I think from the design aspect, there's a couple of things more that we could do to just even make an entry or introduction level study be a little bit more useful in terms of what kind of conclusions we could try to start to draw from it.
Yeah, I totally agree. And I think, some of the limitations they did mention, and you also were, I think, starting to sort of allude to this, is just the lack of sort of sociodemographic data and other things that are really, really important when we're thinking about patients in their entry into the emergency department. So these are things that really need to be accounted for, as many of the sociodemographic and social risk factors. Topics that we are going to hopefully talk about today with Dr. Lili Chan, who is our guest today for episode 5 of the podcast. And we're really looking forward to our conversation with her.
Yeah. In fact, you know what? Let me just go ahead and get started with introducing her. Dr. Lili Chan is an associate professor of medicine in the Division of Nephrology, as well as the Division of Data-Driven Medicine and the Institute of Personalized Medicine at Icahn School of Medicine at Mount Sinai in New York City. She is board certified in internal medicine and nephrology. She obtained her medical degree at Drexel University College of Medicine and completed a master's of clinical research at Mount Sinai. Dr. Chan cares for patients with a variety of renal conditions ranging from acute kidney injury to end-stage kidney disease. In addition to patient care, She is an NIH-funded researcher with a focus on examining and identifying methods, including the use of machine learning and natural language processing to improve outcomes in patients with kidney disease by evaluating unmet social needs and interventions to address structural racism in the care of patients with kidney disease. She is involved with medical education and is currently the Associate Program Director of the Nephrology Fellowship at Mount Sinai, and we are so happy to have her here.
Welcome, Lili. Can you tell us about your background and what made you sort of interested in this field? I know you're sort of at the intersection of nephrology, AI, research, health disparities, social determinants of health. So maybe talk about how you got there and sort of your journey along the way.
Sure. So I am an associate professor in the division of nephrology. So I'm an adult nephrologist. I care for adult patients with kidney disease. I joined Mount Sinai 10 years ago this year, and I came in initially as a clinical trainee, not anticipating doing research. And then during my fellowship, I switched to a research track, did an extra year of research, and also got my master's in clinical research here. I think it comes like the actual research interest in social risk, social needs, social determinants of health comes from a lot of different places. One is I am a child of immigrants. I was born and raised in Chinatown, New York, where my parents don't speak English. And so I kind of grew up in that kind of environment, having to translate for my parents when I was like 10 years old when they went to the doctor. Second part is as I started my physician journey and really taking care of our patients, seeing how much these unmet social risks and needs are impacting their care, how homelessness can actually lead to increased hospitalizations, longer lengths of stay, patients not getting the medication that they need. And it is particularly prevalent in our patients who have kidney disease and are on chronic dialysis. So that's where the topic interest kind of came in. And then the methods aspect also kind of came along as we were just starting out on talking about natural language processing and looking also at patient symptoms and finding new ways of identifying these different potential risk factors that we don't normally account for, and not wanting to do hundreds and thousands of hours of manual chart review and finding a new way to identify that kind of led us down this path. So it's kind of the intersection of like personal history, exposures, and then trying to find a new way of working all that together.
Well, that's amazing. And so for the non-experts, these new ways, we are on an AI podcast, so that's kind of what we're going to focus on. But we always try to start off kind of a broad-based definition for AI. So in your work, how do you utilize kind of a working definition for AI? What does it mean to you?
It basically means training a computer to kind of think like a human, right? So for NLP or natural language processing, we do a lot of teaching the computer how to read the text for us so that we ourselves don't have to read it. And that's kind of my working definition.
Absolutely. And for our listeners who are maybe not in the research space, that is, as Dr. Chan just took us through, it's extremely helpful when you're trying to do manual chart reviews, which are laborious, lengthy, and costly. Data extraction is one of the main elements that she's focusing on.
I think also we're sort of interested in looking at kind of your research portfolio as a whole, and wondering if we could talk a little bit about kind of what you're engaged in or how you sort of got to the research you're doing now, maybe some of the grants that you're supported by, and how that sort of utilizes some of this AI technology or machine learning algorithms and natural language processing for clinical research.
Yeah, sure. I think it actually kind of nicely evolves, as research often does, is almost 5+ years ago now, we started using NLP to see if we can identify different patient symptoms in the medical record of patients who were on chronic hemodialysis. We do know that certain symptoms such as fatigue is reported in over 60% of our patients who are on hemodialysis. So we were able to use NLP to identify these symptoms with high sensitivity. What we did ultimately find, this is again only in retrospective data. One of the major criticisms that we did have is that we're simply depending on what's documented to be our reference standard when we were comparing how good the algorithm was. But what's documented is not actually reflective of the symptom burden that patients are actually facing. And so we then launched into a small prospective study looking at whether or not what's documented compares to what patients report compared to how providers are recognizing This paper isn't published yet, but I can tell you that while our algorithms to identify symptoms is really, really good, documentation of symptoms overall is not so great. And this often depends on the templates that are used by our colleagues. A lot of times they're just check boxes, and if that symptom isn't part of your checkbox list, then it's not going to be included in your documentation. So from that kind of symptoms work, we sprung off into what else can we use to identify, what else can we identify using NLP. And so now this is morphed into a bigger study looking at social risk in our patients, again, on hemodialysis. And so we've actually completed prospectively surveying over 300 patients using a CMS social risk screener. And we do at least find that almost over half of our patients do have at least one unmet social risk factor, and that we don't yet know if it's recognized or not. I haven't yet run the NLP on it, but I suspect overall, at least on our manual review of some of the notes, this is overall poorly documented. We have also done some analysis to see whether or not having a social risk is associated with differences in quality of life. And we reported this as an abstract last year, and that patients who have at least one unmet social risk factor have lower quality of life. The next step is to see whether or not NLP can identify these social risks, and then also whether or not the inclusion of these social risk factors into models for clinical outcomes, such as hospitalization, actually improves model performance. And so, and I know that's kind of a long spiel, so maybe I should pause.
No, I mean, that's great. And I think just to kind of put some common terminology down, so social risk versus social needs, someone presenting to the hospital in need of some sort of help or assistance, and then the social risk being someone presenting to the hospital having some sort of predisposition towards being at risk for a social factor, and then the need being that they're actually looking for assistance, that they do want help. So the difference of breaking down what we normally talk of is just the general social determinants of health. There is kind of two aspects to that. And then, just following up on that, so social risks, obviously we want to know if our patients are at risk, but then I guess kind of that next step is, how do we meet their social needs once we find that they're at risk? How do you see maybe AI helping out with that, and kind of give us your game plan for kind of how you're going to address this?
So thanks, Dr. Pakma. Exactly kind of how you detailed out the differences between social determinants of health versus social risk versus social need. So the interesting thing is, if we actually look at the social screener social risk screener we used, it's actually called the AHC-HRSN, which is Health-Related Social Needs Screener, even though it's, again, the difference is whether or not that person actually wants assistance with it. So if they want assistance, it's need. If they don't want assistance, then that's really risk. So what we're screening for is risk, but we haven't yet figured out whether or not a person actually wants assistance with that. The way AI can help with this, again, is I think there's a lot of contact points between the healthcare system and the patients. We have social workers, we have peer navigators, there's nurses, and especially in our dialysis population, they're seeing 3 times a week at their dialysis facility. So there's a lot of exposure there. Going to soon be in, I believe, 2025, mandated by CMS that our patients on chronic dialysis undergo some form of formalized social risk factors screener. The concern obviously is we will be screening, but we may not necessarily do anything with it. Is it just going to be another paper that we file away? If it's done electronically, then ideally it's done electronically, and we can actually use AI to create prompts or extract this information and provide it to the provider, or even as a next step saying, hey, having some form of chatbot or an LLM where it's just like, this person has this social risk factor identified, and will then provide information to the person who's screening positive with different community-based organizations or potential referral areas that person could seek help from if they wanted to. So I think that's kind of a natural thing.
Yeah, it sounds great. I think DJ and I have talked a lot about the idea of structured versus unstructured data for social risk factor. And it's always sort of challenging to think about that. I guess a follow-up question is, when thinking about maybe more theoretical models, or kind of like, how do we use this data What are your thoughts about how to integrate it into like a clinical model, for example? So you have a patient who has underlying end-stage renal disease, they're on dialysis, and you identify several unmet social, risk factors. Is there a way that you've conceptualized in your mind how to model that and how those factors sort of play into clinical outcomes, progression of other diseases or changes in medication needs and things like that? So, because I think one of the questions is you get all this really rich and amazing granular data. It's like, how do you use it? I think the linkages to community organizations is pretty standard idea, and I think that's probably the most important. But just kind of wondering, thinking like maybe a little bit more big picture, how you might approach that.
So there's been a lot of research on how these social risks and social needs may potentially impact different outcomes. A lot looking at education and income, particularly whether access to kidney hospitalization risk. There are clinical models for those different outcomes. To my knowledge, they haven't yet incorporated AI into it, but there are several ways we could build these models because it is very complex. Part of the problem, again, is whether or not though that information exists in the electronic health record already. And I think there has been a big push to increase documentation of those in a structured format in electronic health record. I still think it's predominantly missing in our patients.
Right, completely. I think one of the major controversies around decision rules from the EM perspective has been the eGFR and kind of the recalculation of that. To me, it stands as one of those examples of how we can get really hyped on something and then it gets implemented and then we look at it and kind of in the post processing and say, oh, well, this isn't working well for everybody. Do you see kind of that sort of bias being replicated again when we now use AI for our decision rules, or AI is implementing the decision rules for us? How is that something maybe that if you do see it as an issue that we can start to kind of prepare for earlier and maybe try to mitigate that bias before it is actually clinically enacted?
I think that could be a huge issue because if your starting data is biased, then your model is going to be biased and there's just going to be perpetuation of those biases, right? So, for example, I mentioned earlier that there is no standardized screening for social risks and social needs in general, right? So, are the people who just have that information, is it more common in certain populations over other? If that is true, then we're going to have a lot of data on a certain population who we know have more risk, and we're going to assume that those other people don't have those risks.
Don't have risks. Yeah.
So unless the only way to really mitigate this is that if we must institute standardized screening so that data is collected equally across all people.
And that's a really important point, I think, because a lot of the pushback that you hear when we talk about implementing standardized screening is, well, we're going to start screening for things and then we won't have kind of the resources to address everything we're screening for. But I think on the flip side, what you just presented is a great kind of reasoning as to, well, our models that we're going to be depending on, if we're not screening everybody, then we're by definition biasing them, right?
I do think that also gets tricky because if we now conduct standardized screening, what are people supposed to do when they screen positive? One of the questions on the CMS screener is actually about personal safety. So is it really ethical then to screen positive, identify a person who is not in a safe environment and to do nothing? So before we say, I absolutely agree we need to do standardized screening, but we also have to have a plan in place when people screen positive for things that can directly be detrimental and immediately be detrimental to.
Absolutely.
Yeah. Do you think large language models and NLP can help to sort of streamline and leverage this data in the context of the electronic health record? I think one of the things that we as emergency medicine physicians deal with on a daily basis is just wrangling the electronic health record.
I am primarily a consultant. When I get a new consult, I can tell you how much time it takes me to dig through all of the existing progress notes, review creatinines from the past 10 years, their urine samples from 10 years. If I didn't have to personally just click on all of the notes, so from the past 5 years, that would be a huge time saver. Some LLMs, such as ChatGPT, was integrated into our electronic health record, and I could simply write a prompt, give me a summary of the trends in their creatinine, or tell me about the changes in their kidney size on imaging. Like that would be, in my mind, groundbreaking. and a huge time saving for all of us. And I get this would be useful for, not just my field, but all fields across medicine. So there's different types of concern with these implementations, but I do think there could be a lot of benefit there.
Yeah, and I think there maybe Epic's listening to us or some other vendor, but I'm sure they're going to work on this. It strikes me as that it might need to work differently for different contexts. As you just said, you're a consultant, so you're looking at 10 years of data. And while I may want 10 years of data very neatly summarized for me, I don't want to look through 10 years of data, right? It's basically this ability to summarize text. And so again, another function of LLMs. And maybe that makes kind of a question that I think instinctively we kind of work through and haven't really talked about. But what do you see as the main difference between something you would use a natural language processing, a pure natural language processing methodology for, versus something that is better used for, an LLM would be better used for?
What I found is that NLP, or what I would call traditional NLP, is really good at entity extraction. So identifying diseases, identifying specific things that we're looking for. But when LLMs are just far superior for generation of text and also summarizing of text, right? So a lot of, I think the field is just moving towards LLM, and which also makes it easier, more user-friendly, because not everybody in medicine or even in the world is very technology savvy. And then to have to build standardized queries to extract our specific thing, that's traditional NLP. LLMs, they can take our normal speech writing and actually transfer that into a standardized query so that it can understand and actually provide that information to us. On the patient side also, I think a lot of what we do is education for our patients. LLMs are going to be able to take information and actually give it to our patients at their various reading levels so that they can increase comprehension that way also.
Yeah, I think that's a great point. Generating very precise discharge instructions for patients that address not only their medical literacy, but also their specific needs. Because I think right now the discharge instructions, at least in emergency medicine, are very generic and don't really reflect the individual patient. So I think that's something we've talked a lot about over the last few episodes when we've interviewed people from various fields and backgrounds in this space. I wanted to maybe pivot and talk a little bit. I don't want to put you on the spot with this paper, but I thought it was a great publication that you had put out entitled Comparison of Predicting Cardiovascular Disease Hospitalization Using Individual Zip Code Derived and Machine Learning Model Predicted Educational Attainment in New York City. That was just a really interesting paper. If you're comfortable sort of talking about and summarizing what you found and your approach, I think it'd be really interesting for listeners to understand taking all these different data sets and using them to come up with some really interesting results and models.
Yeah, thanks for bringing up that paper. It actually kind of stems back to the study that I was talking about assessing social risk. So part of that is we also collected patient street address and zip code information. And what we were finding is there's kind of two schools of research when we're talking about a person's social environment. You have the neighborhood level, and then you have the individual level. And it's really difficult to get individual level because you actually have to directly survey them, or someone at some point must have asked them. While the neighborhood level, there's a lot of information that's derived from the U.S. Census. And you can take the person's zip code or street address and map it to the area education levels. And what we were finding is that in our dialysis patients on dialysis, that what we were seeing from their reported income and education didn't really match what was getting derived from their zip code information. So we took that kind of research question, like, is this true in general, and expanded it into the BioMe Biobank cohort and compared the survey education level with the zip code derived education level. And we found that there was marked difference. So I think less than half of patients actually matched what was estimated based off of their age, race and ethnicity and gender. From that, we were like, well, we have all of this information on them based off of their EHR. Is it possible for us to then predict their individual based off of the information we have in the EHR and also where we live? And with that addition, we did see a much better, I think it was a 20% point difference compared to just using the census zip code. And then we, again, kind of asked, like, does inclusion of this information then actually improve on clinical model for different clinical outcomes? And so we use cardiovascular outcome for our paper here. And what we did find is that patient reported, which is going to be the most accurate, had the best performance of the model. But when we actually compared that to the zip code versus the model derived, we did also find that our model derived was superior to the zip code. We'd love to expand on this. Right now, it's only been on education, and the limiting factor is in order to train our models to make this prediction, we actually have to have actual survey results. And so we're looking into different sources on what patients, where we can have a large number of patients who've actually filled out this information before.
One follow-up question, I guess, is DJ and I have both done sort of research using area level measures. And I think what are the implications of that? Because I think there, certainly when you use area level measures as maybe as a proxy for predictors of individual level health outcomes, even if you employ, very sophisticated statistical techniques or machine learning, you do find that they're not always reflective of individual level, which I think you stated well here. What do you think the implications, or where should that sort of whole field of research go, given some of the results you found in this particular study?
I think we just have to recognize it's still a useful area of research because it does also matter where you live. And so what we can't do is we can't extrapolate simply that where you live is reflective of that specific person. And that's also very true of New York City's, particularly, my Sinai Hospital. On the one side, we have the New York City housing apartments. And then on the other side, we have Park Avenue, Madison Avenue, Central Parkview. And so same zip code, very, very different people.
Yeah, and I think that's probably more problematic in New York City than, say, it would be in like Omaha, Nebraska. I haven't looked at the data for Omaha, Nebraska. But, we tend to be kind of on top of each other. And so there's a lot more ambiguity and heterogeneity in any of our data. And I guess that kind of brings me to the question, going forward, we've talked about risk, needs. How do you see AI transforming the actual obtaining of that data? Would it be through a virtual healthcare agent? Would it be something that we embed in the patient portal? How do we actually get that information to the patient in a way that is reliable, consistent, and available to researchers? I know this is $1 million question. Maybe Ethan was right about me asking hard questions.
I think I agree with Ethan here on that, mainly because I don't think there is a clear answer, right? One thing is, I don't know when the last time you guys saw a doctor was and how many forms did you have to fill out just to get checked in? Do we want to increase the person's burden just to see their medical doctor? I think it's also important, though, to screen because a lot of people won't have any of those problems. There are people who will have these needs that might benefit from that. So that's why I was like, it's a hard question because I don't think there's a good answer or a good balance. The way AI can be used to address this is kind of like you mentioned, there's a lot of virtual assistants, a lot of chatbots out there now, but that still then requires a person who either wants to fill it out or do I think it's going to increase us screening? Probably not. Do I hope that'll at least increase access to resources for people who are looking for it? Yes, but also a caveat being we could talk about the technological inequities and all of that too, if we want to get into that. But yes, that's kind of my hope is there's a lot of resources out there. I don't think everyone knows about them. And getting that information to the right hands is where I hope that we can do it.
How do we think about safety when patients are probably maybe naive to it even more because they don't know that some of these models are running in the background? So how do you picture moving forward with safety, and especially when we're getting to that deployment stage? What are your thoughts on that?
I think I'm going to also add Dr. Abbott to a hard question asker because, again, it's just not simple and it depends on the intent of the model, right? So a lot of what I do is, hey, this person might have this unmet social risk and you should screen for it. That is not a big burden on anybody and has a huge reward side of actually identifying an unmet social risk that we could intervene on and refer patients and have that addressed. The more complicated ones is when we're saying, hey, this person has AKI, bad heart failure, and we're about to start them on this life-saving procedure, but our model predict that even with this procedure, they're only going to have a 10% chance of survival. Is that going to impact a person's clinical decision, meaning that they're now not going to offer that to a person? How many false positives are we going to allow? How many people are we going to say that this is not true for one truth? And so it's a really difficult question because it really depends on the intent of the model. It'll also depend on the circumstances and all of that too. Overall, laws always lag behind technological advances, and we do need additional oversight and more guidance so that people aren't building models and then implementing them, even though the models might not be good, meaning that they don't have good performance metrics. So there has to be that general oversight, but a little bit of nuance too, because what's the goal of the model?
I have two questions, and then they're kind of, they dovetail into each other. So the first one is for emergency physicians out there. Given your background, what would you want us to take away so that we can better take care of your patients when they're passing through the emergency department?
Our patients are very sick and they have a lot of things that we are not aware of, and we need to do a better job of finding that out from our patients.
So screening, definitely. And then I guess if you were starting out all over again, and you don't have to be an emergency physician, you can still go into nephrology, but what resources, what kind of things would you be looking for to take the temperature of the space and to then figure out if you wanted to dive in further?
The space meaning AI, NLP,
AI,
LLM.
informatics. Yeah, exactly.
I would have liked more computer science exposure. And that doesn't necessarily have to be like actually coding, but even just the understanding of the logic or working with engineers, because that's a lot of what I think we do now is work with our data science colleagues to understand what they're doing and also to explain our research questions to them in a meaningful way. So communication and also data structure. EHR is so messy, and to understand relational tables and how to correctly, identify different columns and things like that is also very important.
Perfect. I will end my onslaught of questioning there for the day.
Awesome. Well, thank you, Dr. Chan, for joining us on this really interesting episode. I think we covered some amazing topics here, and we want to thank you so much for your time and effort to be here. So thank you.
Absolutely. As well as all that you do for your patients. And, for all of our listeners out there, again, when we have our patients who have different kidney issues or renal issues, make sure that we are, doing a little bit deeper dive kind of on those social needs and social risks. And we'll all be happier and better for it.
Thank you, Bill. This is fun.
Thanks so much for listening to episode 5 of the Stat AI podcast. Don't forget to tune in next month for an exciting new episode. Take care.
Please note that the views, opinions, and information expressed in this podcast are solely those of the individual speakers and do not necessarily represent those of their employers, our sponsors, or any affiliated organizations. The content provided is for informational and educational purposes and is not intended as medical advice. We encourage you to consult with qualified healthcare professionals for any medical concerns or treatment decisions. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. Listener discretion is advised.